Okay, so now chapter 40 is what we're going to go over, which is diabetes chapter. And this starts on page 815. So again, I'm going to do your PowerPoint slide and record at the same time here. So, diabetes is a group of metabolic diseases in which defects in insulin secretion or action result in elevated blood plasma or glucose, leading to hyperglycemia. Again, diabetes insipidus and diabetes mellitus, not the same thing. Diabetes insipidus was the too little anti-diuretic hormone that was secreted. And diabetes or diabetes mellitus refers to diabetes mellitus, obviously. As far as patho goes, we have a glucose intolerance and faulty production of insulin or tissue insensitivity to insulin. So your pancreas and the beta cells of the islets of Langerhans do not make enough or do not make any insulin, or the tissues become resistant to the insulin that the body has produced. Also, we have altered carbohydrate, fat, and protein metabolism, and then long-term complications that can occur with diabetes. Now, do note on page 816, it says when insulin comes in contact with the cell membrane, that's ultimately when our cells would take that glucose in for energy. But with the receptor that allows activation of special glucose transporters in the membrane, and then by helping glucose enter the body's cells, insulin, 1, allows glucose to be used for energy, and then 2, lowers the glucose level in the blood, and 3, helps the body store excess glucose in the liver in the form of glycogen. So those are all important for you to know about diabetes mellitus and the physiology behind that. Now, slide 6 in your textbook is on page 816, figure 40-1, and this just kind of gives you that image of what happens with the pathophysiology. After eating, our blood glucose levels rise as glucose flows from the digestive tract into the bloodstream. Then 2, high glucose levels stimulate the beta cells of the pancreas to secrete insulin. And then with type 1 diabetes, the pancreas does not, zero, insulin is produced, and glucose cannot enter the cells and builds up in the bloodstream, leading to hyperglycemia. And then with type 2 diabetes, you have insulin production being reduced by the islets, beta cells in the islets of Langerhans from our pancreas, and or the cells are resistant to the insulin that our body has made. Less glucose enters the cells and more stays in the bloodstream, again leading to hyperglycemia. So the CDC and prevention statistics, more than 30 million people in the U.S. have diabetes. 84 million have prediabetes, which we'll talk about here in a little bit with the metabolic syndrome, and 245 billion per year in the U.S. associated with diabetes. So it's a big deal for diabetes. Now let's differentiate between type 1 and type 2 diabetes. It's important for you to know this. Former names, insulin-dependent diabetes or juvenile diabetes. When I went through nursing school, it was called juvenile diabetes. It only represents 5% of the cases. Some have a genetic component, which is about 10% of those cases. Autoimmune response to virus. They don't know what causes type 1 diabetes 100%, but they think it is related to being exposed to a virus, which destroys the beta cells in the islets of Langerhans. But again, zero function of the beta cells of the islets of Langerhans. Therefore, the pancreas does not make insulin, and you have to get that from an outside source, and that has to come by way of subcutaneous insulin or intravenous insulin. More common in young adults and thin patients, and these folks are prone to ketosis or DKA, which is diabetic ketoacidosis, which is a complication that we'll talk about. Now, if you look at the bottom of 817, Table 40-1, it compares and contrasts the kind of big issues with type 1 and type 2 diabetes, so you might want to look at that. Okay, so type 2 diabetes, formal names, non-insulin dependent diabetes, and then adult onset diabetes. But this does represent 95% of our diabetic cases, large genetic component equaling up to 90% of those cases. Reduced number of beta cells, so in these cases, the pancreas just decreases its insulin secretion and or reduced tissue sensitivity to insulin, so our cells become a little bit resistant. Largest risk factor is obesity, and not usually ketosis prone, but they may have HHS, which is hyperglycemic hyperosmolar state, which we'll also talk about, and that's again typically a risk for type 2 diabetes. So if you look again at Table 40-1 on the bottom of 817, it compares and contrasts. So type 1 typically is a very rapid onset with the 3 Ps, polyuria, polyphagia, polydipsia. Age of onset usually youth, but definitely younger than 40. Risk factors: virus attacking the beta cells in the islets of Langerhans, autoimmune response, and then hereditary does play a big risk there. Usual body type: very lean adults or people. High glucose complication is the ketoacidosis or DKA, and the treatment diet, exercise, but must have insulin to survive. They cannot live without insulin because the pancreas does not make insulin. If I haven't said that already, the pancreas does not make insulin, so therefore they have to get that from an outside source with type 1 diabetes. Type 2 typically is a slower onset, usually older than 40. Hereditary and obesity is the huge risk factor there. Overweight or obese, usual body type. HHS, hyperosmolar hyperglycemic state. I might have said that a little bit backwards. I learned it as HHNKS back in the day, hyperosmolar hyperglycemic non-ketotic state, because those folks do not have ketosis. And then diet, exercise may need oral hypoglycemic agents, and insulin may be needed if their pancreas finally maybe does quit or is deficient in its insulin production, their blood glucose cannot stay under control. Insulin may be needed, or if they're sick or something like that. Okay, so type 2 diabetes in the youth, this is on page 818 in your textbook. I'm on slide 10. Because we are seeing more obesity in children, type 2 is an epidemic, and it is a nursing challenge that we are trying to deal with. There are also gestational diabetes, pre-diabetes, and secondary diabetes, but gestational diabetes is related to pregnancy. Pre-diabetes refers to blood glucose levels that are above normal but do not meet the criteria for diagnosing of diabetes. They do have some glucose intolerance. And then secondary diabetes related to some drugs, of those steroids being big ones. Phenytoin is another one. Thiazide diuretics and thyroid hormone can also impair insulin action. And then pancreatic trauma can also be a cause of secondary diabetes. Now, metabolic syndrome on 818. This is known as kind of a pre-diabetic state linked to a condition, and again, metabolic syndrome. And by this, it's diagnosed by 5 different things. Central or abdominal obesity, measured by our waist circumference, and in men greater than 40 and women greater than 35 inches. Also elevated or fasting blood triglycerides greater than or equal to 150. Then we have blood HDLs, cholesterol less than 40 in men and less than 50 in women. Then you have blood pressure greater than or equal to 130/85, and fasting glucose greater than or equal to 100. All puts them in that pre-diabetic category. That does not mean they have diabetes, so that is there. Other risk factors for metabolic syndrome include physical inactivity, aging, hormonal imbalances, genetic predisposition. Okay, so then we have signs and symptoms of diabetes. The 3 P's are classic: polydipsia, polyuria, and polyphagia. Polydipsia is going to be increased thirst. Polyuria is obviously increased urination, and polyphagia is increased hunger. And of those are all mentioned on 818 in your textbook. But the excess glucose in the blood causes an increase in serum concentration or osmolarity. The renal tubules become unable to reabsorb all of the extra glucose that is filtered by the glomeruli, and glycosuria, or glucose in the urine, results. Large amounts of body water are required to excrete this glucose, causing that polyuria. Nocturia can also be seen, again, nighttime urination, as well as dehydration. So those are the manifestations that we see. Let's see, high blood glucose can cause fatigue, blurred vision, abdominal pain, and headaches. Ketones, which are acid byproducts of fat breakdown, can build up in the blood and urine of patients with type 1 diabetes or late in the course of type 2 diabetes, which is when you can possibly see ketoacidosis in type 2 diabetes. But again, it's more common in type 1 diabetes. Let's see. They are also infection prone, and ketosis and acidosis, diabetic ketoacidosis. All right, so diagnosing diabetes. Fasting blood glucose of less than or greater than, or equal to 126 milligrams per deciliter. That's what puts them at that risk. If you notice with our metabolic syndrome, with that pre-diabetes, it was a fasting glucose of greater than or equal to 100. So for diabetes, it's greater than or equal to 126. A random blood glucose of greater than 200. Oral glucose tolerance test greater than 200 after 2 hours, and then a hemoglobin A1C or glycohemoglobin that is mentioned on 819 and table 40-2 on page 819. But if you look here, hemoglobin A1C, as far as the percentage, you're looking at if it comes back as 6%, their fasting blood glucose over a 3-month period has been about 126, and if you go up to 12%, that's 298. That their blood glucose has been over the past 3 months averaged. And the reason that we can do that is because we have our red blood cells, and glucose is carried on those red blood cells, and those last approximately 3 months, 90 days of that nature. And that's, I call it our diabetic lie detector test. But for diagnosis of diabetes with your hemoglobin A1C must be greater than 6.5%. All right, so additional tests that can also be done is a lipid profile, again, looking at that, especially triglycerides. In your lipid panel, you're looking at, triglycerides, you're looking at cholesterol, total cholesterol, and your HDL cholesterol. LDL cholesterol is also in there, and that was one of your pre-diabetic or metabolic syndrome risk factors as well. Urine for microalbumin. That's one of the first tests that can be done. Albumin should not be spilt over into your urine. Well, you can have very minimal amounts, but when you start seeing abnormal albumin in the urine, that is an indicator of that, and albumin is a plasma protein. UAs we also get, and electrocardiograms can also be done for diagnosis of diabetes. Prevention of type 2 diabetes. 7% body weight loss is huge for folks with type 2 diabetes. Moderate physical activity equaling 150 minutes per week, averaged at least over 3 days. Metformin in some patients. So if you look at the goals of treatment on 820, sit down. Don't get up. You can see these all listed on 820, but goals of treatment recommends that most patients maintain a preprandial, which is pre-meal blood glucose of 80 to 130, a peak or postprandial, which is post meal, of less than 180. And then nutrition therapy. For nutrition therapy, it doesn't have to be diabetic foods. It doesn't have to be low carb. What they recommend, and you can read this on 821, that many different people have many different needs, and ultimately a well-balanced diet and having the same amount of carbohydrate intake on a daily basis. What really gets folks messed up is when they have, really big peaks and troughs with their meals, they fast or do whatever, and that really messes with their blood glucose levels. So well-balanced and individualized plans are what is recommended by nutritional therapy. Again, exercise at least 150 minutes per week over 3 days. The big thing with exercise, though, is that exercise does lower blood glucose levels by reducing insulin resistance and improving insulin action. So they have to really watch their blood glucose levels. So it's important with persons with diabetes who take insulin or medications that increase insulin secretion should check their blood glucose before exercise, and always carry a quick source of glucose when exercising in case their blood glucose drops too low. Here's our, I'm on slide 17 of your PowerPoint, the preprandial, the peak postprandial, the blood glucose, or blood pressure, and glycohemoglobin of less than 7%, all recommendations. So here on slide 18 is the nutrition therapy that I just mentioned, the exercise. Now let's talk about medications. Medications can include insulin. Obviously, insulin is a requirement for type 1 diabetes, but you can also have oral hypoglycemics, which we're going to talk about, and those are our two options for medications. And then monitoring. It talks about self-monitoring of blood glucose, and then continuous blood glucose, and obviously treating accordingly, and then education that would be involved. So nutrition therapy. Carbohydrate counting, again, is not a requirement. It's a good thing to do. You should have roughly the same amount of carbohydrate intake on a daily basis. Now, does that mean eat all the carbs that you want? No, not necessarily. So you have to have that well-balanced nutrition. Their glycemic index and load, the difference between somebody eating we'll say a whole wheat piece of toast and an egg versus a honey bun for breakfast. The simple sugars in that honey bun are going to really spike that blood glucose, as well as for somebody who eats a complex carbohydrate. The whole wheat toast is going to be more of a sugar spike of this, as opposed to that honey bun, which goes pew, and then kind of down here. And so we don't want those spikes. You want to have that moderate carbohydrate intake, so a well-balanced diet, and it's, again, individualized. Creating your plate, and remember cultural dietary needs. This is talked about on the cultural considerations on 882, so we have to take all of those into consideration. Because not all cultures are the same as far as their dietary intake, so we need to not tell folks you cannot have this. We have to work those needs into their diet. All right, so general principles. Type 1, avoid wide swings in blood glucose. Again, we want to keep their blood glucose here as opposed to spiky up and down, up and down, up and down, because that's really hard on the body. And then type 2 control is controlling their blood pressure, controlling their weights, and controlling their lipids. And how do we do that? Weight reduction, exercise, low fat, well-balanced diets, and eating on a regular schedule. Typically, those folks with diabetes, we recommend, small, frequent meals every 4 to 5 hours, and doing that. So here's the plate method that's talked about on 821 under the nutritional notes, and carbohydrate counting. So this is important, and again, if we teach them to carbohydrate count. 15 grams equals 1 exchange, so that would be considered, if they are carbohydrate counting and they have an insulin pump, for instance, you take how many grams of carbohydrates they eat, and then you would kind of tie that into the units that they would administer to themselves with those type 1 diabetics. So that can become important for those folks. So anyway, 15 grams would equal 1 exchange. And typically you give, you count up your carbohydrates, and just do that for a couple of days and see what your carbohydrate intake for a couple of days is. All right, so exercise, again, I've already talked about this. So I've talked about all of those. So medications, insulin for type 1 and type 2. Again, type 1 diabetics have to have insulin. They have to, because their pancreas does not make any insulin. Type 2 diabetics can control their diabetes with diet and exercise, but they may need the addition of oral hypoglycemics, which can include metformin, glipizide. Those are the 2 big ones that we give. Other injectables, they have come out with those, which are not the same thing as a true insulin. So let's look at each of these. So insulin, you have to know the onset, peak, and duration of these. But insulin lowers blood glucose. Again, it has to be taken by a type 1 diabetic. You can give insulin subcutaneous route and IV. The subcutaneous route can also be in an insulin pump, but that is a route that you can give insulin. And insulin pumps, those are typically what we look at when I was talking about that carbohydrate counting and giving a basal rate of insulin, meaning that they're getting a constant kind of trickle of insulin 24 hours of the day, and when they eat, they bolus themselves with that insulin because their pancreas does not make any insulin, and they have to have that in order to manage those spikes that we do take in with our dietary intake. So site rotation is also very important. I'm sure that you're aware of this, but as far as insulin injections go, you have to know your timing, onset, peak, and duration. Again, and it's very, very important. That's on page 823. So we have 4 types of insulins here. You have very short acting, which is also called rapid acting. You have short acting, you have intermediate acting, and you have basal or long acting. And what we typically are looking for most problematically is that peak kind of time frame when patients are at highest risk for hypoglycemia as a result of these injections of insulin. So that becomes a really big deal. So for rapid or very short acting, the peak duration, depending on which insulin you're giving here, it can be insulin Lispro, which is Humalog, insulin Aspart, which is Novolog, and then inhaled insulin, which is, I've never given inhaled insulin, but it is available. But the peak can be anywhere from 30 minutes to 3 hours. So again, looking at that highest level of risk of hypoglycemia is very, very important. And then duration comes along with how often they may need to get that insulin to make their blood glucose levels stay within normal range. So if you think about short-acting insulin, which is regular Humulin R or Novulin R, the peak is 2 to 5 hours, and then the duration is every 5 to 8 hours. So it stays in the system for 5 to 8 hours. So if we needed to treat a patient based on, a sliding scale insulin protocol, that's why we typically give those ACNHS or every 6 hours and administer that insulin. But if you have somebody that's taking NPH or Lantus or insulin glargine, that those are longer acting insulins. The NPH or Humulin N is an intermediate acting. Its onset is its peak is 6 to 12 hours. But its duration is 18 to 26. So they're likely only need that maybe Q12 hours or Q24 hours, depending on what their glucose levels are. But basal or long-acting insulin, there is no peak for that, and it's up to 24 hours duration. So again, that would be a medication that would be administered only Q24 hours or even longer if the patient could not tolerate that. So that is very, very important. So again, regimens, basal bolus versus sliding scale. That's mentioned on, let's see. On 824, but a basal bolus therapy mimics normal insulin secretion, and that consists of an injection of basal insulin, such as insulin glargine or Lantus, which is once a day, so that gives you that treatment and that duration carrying you over. Then a sliding scale insulin is going to be provided for those boosts that we may have with eating and sleeping, and that are evening snacks. So that's what a sliding scale insulin would do. And people, again, are individualized based on this. I always tell folks that when you're dealing with somebody, especially that's dealt with diabetes and type 1 diabetes, and they take insulin routinely, and your sliding scale is a little bit different, you go in and say, hey, your blood sugar was, we'll say, 286, and it orders me to give you 12 units of insulin based on the sliding scale, and they tell you, oh my gosh, if you give me that much insulin, I'm going to bottom out in 30 minutes. Listen to them, because they know and typically are not going to just blow your chops. So you might say to them, well, what would you typically do for your this insulin or this glucose level if you were at home? Now, keep in mind, however, illness does increase blood glucose levels, and you have to inform those patients of that. So you might have to factor that in. If they say, oh, if you give me 12, I'd probably take only 8, I might say to them, well, remember that you're sick, and when you're sick, your glucose levels increase. So how about we kind of take in between that and maybe give you 9 or 10 units of insulin, and we'll see how you do, watch you really close, that sort of thing. So just keep that in mind. Okay, so insulin pumps, again, mimic kind of what our pancreas normally does. These are great tools. And with insulin pumps, we can have them constantly get that little trickle of insulin, which is the same amount all day long. And when they eat, when they exercise, whatever, they will bolus themselves. They'll plug in how many carbohydrates they just ate, and it'll tie that in and deliver that insulin. And it's, again, delivered subcutaneous. It's a great tool to have for young adolescents, so it's great. So let's also talk right quick about, I'm not sure, insulin pumps were mentioned on 822, but where does that talk about that at? I guess that's on the mixing. No. Yeah, that'll be a little bit later. All right, so oral hypoglycemics. These are mentioned on 825 and 826 in your textbook, table 40-5. These are not insulin. The action depends on the medication. They can actually stimulate the pancreas to make more insulin, or make your insulin be, I guess we'll say, more potent. And then they can increase tissue sensitivity to your insulin. They can slow our carbohydrate digestion and absorption, and reduce glucose reabsorption by the kidneys. So all of those can be different mechanisms of action for oral hypoglycemics. And then amylin analog for type 1 diabetes, pramlintide or Simlin. is mentioned on 824, and then incretin mimetics type 2 diabetes, and that's exenatide or Byetta and liraglutide Victoza, which are kind of some newer drugs that are out there for injectable agents. All right, so self-monitoring of blood glucose is mentioned on the bottom of 824. We want to test AC before meals and at bedtime for an hour of sleep or as ordered, typically for those folks who have diabetes or come in with illnesses and their blood glucose is all out of whack. This is what we'll do. We want to record the results, analyze meaning of the results, and what does that mean? We're looking at the levels and seeing if we do need to call the physician or notify the RN if they do not have sliding scale insulins provided. Know our target glucose levels, normal levels 70 to 100, and then for somebody that might be ill, and then call the provider if out of range, if they don't have orders for that. Okay, so here's a glucose diary for a patient to keep up with if they do have diabetes, and that's on page 826, figure 40-7, and that's a great tool, especially for when they're dealing with their diabetes with a healthcare provider outside of the acute care setting. And then urine testing. This can also be done at home, especially when a patient's sick, but glucose no longer recommended unless self-monitoring of blood glucose is impossible for dipstick of urine. And then ketones, if our blood sugar is elevated and the patient is at risk, especially if they are type 1 diabetic, they need to be able to note if they have ketones in their urine, because if that's the case, they need to get some help and take care of that as quickly as possible. So alterations in blood glucose. So let me just right quick talk about other monitoring of blood glucose. So on page 826, it talks about new devices that are available that continuously monitor glucose via a small catheter. I took care of a patient maybe last summer that had one of these. Most awesome thing ever, because I didn't have to stick him for his blood glucose levels. He just had a little sensor, had this implanted subcutaneous catheter. His was in his arm. This one talks about it being in the abdomen. But the device records and gives the patient an immediate feedback. And these are especially good when frequent episodes of hypoglycemia are seen or a patient's very brittle. Great tools to have. Okay, let's see. All right, so now there is a diabetes summary on page 827 in your textbook. It talks about the signs and symptoms, the diagnostic test, so it's kind of like a little summary of diabetes. So now let's talk about alterations in blood glucose. This starts on 827, acute complications of diabetes. So we have hyperglycemia and hypoglycemia as a result of having an insulin reaction. So hyperglycemia is considered that blood glucose of greater than 126, and the causes can be from overeating. Stress is huge as a result of having hyperglycemia and diabetics. So any type of stress, a job, an illness, trauma, whatever, is a major cause of stress or a major cause of hyperglycemia, and that's on 827 again. Illness and then not enough medication. So they have problems with, their insulin may not be enough, or their oral hypoglycemics may not be doing just cause. They may not be taking them correctly, whatever. Okay, so signs and symptoms of hyperglycemia, again, there's those 3 Ps, polyuria, polyphagia, and polydipsia, blurred vision, fatigue, lethargy, headache, abdominal pain, ketonuria, so ketones in the urine, and coma can ultimately happen. And treatment for hyperglycemia. So with treatment, we want to check their blood glucose, check it often, especially if they're ill, they may need to check it more often. The use of sliding scale insulin, checking their ketones as needed, determine and treat the cause. If blood glucose is greater than 180 for 2 days, call their healthcare provider. And again, calling their healthcare provider if they become ill or are vomiting, because that can really throw off a patient and make them have those complications associated with type 1 or type 2 diabetes, diabetic ketoacidosis, and HHS, hyperglycemic hyperosmolar syndrome. So they really need to watch that. All right, so hypoglycemia. Well, I didn't talk about the morning hyperglycemia that can occur. So let's talk about those two things right quick on 827. Dawn phenomenon and the Samoyed effect. Those are listed. The dawn phenomenon is caused by normal hormone fluctuation during the night, as well as a release of stored glucose leading to morning hyperglycemia. So that would be a morning hyperglycemia phenomenon. And then the Samoyed effect occurs when the blood glucose drops too low during the night due to a missed snack or too much insulin. Maybe you gave the insulin and didn't give the snack, but the body responds by releasing those counter-regulatory hormones, epiglucagon, corticosteroids, and growth hormone, which then rebound with the hyperglycemia in the morning. For treatment or diagnosis of these, you do monitoring their blood glucose, especially between 2 and 4, to determine the difference if they're having the dawn phenomenon or the Samoyed effect, and treat accordingly. All right, so hypoglycemia now on the bottom of 827 and on slide or PowerPoint slide 37. So low blood glucose or hypoglycemia occurs when there is not enough glucose available in relation to circulating insulin. And typically this means a blood glucose less than 70. And causes can be from the patient taking in too much insulin, exercise, which we've talked about, or not taking in enough food. And that can be from starvation diets, diets just in general, or illness, because when you're ill you might not feel like eating, so therefore they don't take in enough food and they become hypoglycemic. So symptoms of hypoglycemia. Initial symptoms are activated or caused from the activation of our sympathetic nervous system, and these may include hunger, sweating, pallor, tremor, palpitations, and headache. As that hypoglycemia does progress, the brain is deprived of glucose, and neurologic symptoms can occur, such as irritability, confusion, seizures, coma, and that's your symptoms of hypoglycemia. Let's see, there is a, hold on just one second, warm and dry, glucose high, I think is how the little saying goes. Cold and clammy, need some candy. I think that's how it goes. Or hot and dry, sugar high, cold and clammy, need some candy. So that's what the skin may be with that. I can never remember that for some reason. Let's see. That's where that cold sweat comes into play. So treatment of hypoglycemia. This is on page 828. Obviously, we want to check their blood glucose for any symptomatology, and administering 15 to 20 grams of fast-acting carbohydrates. And those fast-acting carbohydrates can include 4 ounces of OJ, 4 ounces of regular, not diet soda, 8 ounces of low-fat milk, miniature box of raisin, commercial glucotabs, and those are typically, one tab is 15 grams, or actually I think one tab is 5 grams. I think you're supposed to take 3 of those. And then 6 to 8 lifesavers or other hard candy. Again, a rapid acting sugar or carbohydrate is what you ultimately want to do. And you can remember this as a 15 and 15 rule. So 15 grams of carbohydrates, and recheck their blood glucose in 15 minutes. Repeat as needed. Snack if longer than 1 hour until their next meal would be indicated. So that's kind of what your treatment of hypoglycemia is. Now, with a person that, this is obviously with a person who is alert and oriented. So obviously if you had a patient that was not alert and oriented, you would not want to give them anything like oral things. So you might have to give them glucagon. And let's see, there's your examples of your fast sugars. So acute treatment, IV dextrose 50% or subcutaneous or intramuscular glucagon can be given. So now let's talk about complications of diabetes. We have DKA and HHS. So DKA is diabetic ketoacidosis, and it causes increased blood glucose, hyperglycemia, and again, it's most common in type 1 diabetes, and it's typically brought on by stress and illness. Lots of times folks that have type 1 diabetes, this might be their first initiation with it and their first admission to the hospital. Lots and lots of people come in with DKA and don't know they have type 1 diabetes, and that's how they find out because they're so sick. But with these folks, well, let's talk about patho first. So we have an insulin deficiency. The cells are starving, the fats break down, and the byproduct of that is then ketones. So you have ketones in your urine, and ketones are very acidic, and that's why you have the acidosis associated with that. So a pH of less than 7.35 is what's seen. So our signs and symptoms. So these folks, increased blood glucose, acidosis, pH of less than 7.35, ketones in their urine, dehydration, so they have those 3 P's, but they are what it will say times 100. So they have polyuria, polyphagia, and polydipsia. So they come in very, very dehydrated. They also present very commonly with flu-like symptoms, which are mentioned at on page 829 in your textbook. But they also may have Kussmaul's respirations, which is a deep sighing respiratory pattern, and then they also may have that fruity breath from ketones that are in their bloodstream. They also have electrolyte imbalances, and dehydration, coma, and death can ultimately happen. So with that, with their dehydration comes along the tachycardia, the hypotension, and that hypovolemic shock can occur as a result. Acidosis, again, causes the potassium to leave the cells and accumulate in the blood. If you remember back what acidosis, alkalosis was, the K was low, so acidosis is hyperkalemia. But what happens when we start treating their DKA and the potassium starts shifting back into the cells, then they can have problems with hypokalemia. So we have to watch for that very frequently. So as far as therapeutic measures go for these folks, they're dehydrated, they're acidotic, they're hyperglycemic, so we need to treat all of those things. So first and foremost, we're giving them IV fluids, lots of them. We're starting them on IV drip. The only insulin that can be given intravenously is R, Humulin R. Frequent glucose monitoring. These folks are typically admitted to the ICU, and we're doing Accu-Checks Q1 hour and monitoring and treating their electrolytes accordingly. Typically we'll start them out on just saline, and as their blood sugar starts to return to normal, your book says 180, then they put some dextrose in that. Where I work, it's 250 because they can come in with blood glucoses of 800, 900 milligrams per deciliter. So when we don't want them to get hypoglycemic, so we will change that over and put a little bit of dextrose in those fluids, so maybe D5 half normal saline or D5NS, and then also watching for that potassium because they will go from hyperkalemia to hypokalemia very quickly, so you have to watch for that. All right, so prevention is to check their urine ketones. So we do that at home, especially if they're ill. Check their blood sugar. If it really starts on that trend upward, they really need to watch it, especially during stress or illness. And then good diabetes control is the ultimate goal. So hyperosmolar hyperglycemic state, or HHS. Typical, again, hyperglycemia in type 2 diabetes, again caused by stress and illness, and it's most commonly seen in the elderly. I've taken care of quite a few folks that, or elderly folks that have had HHS. Again, these folks do not have the ketosis. They will have the same presentation of high blood glucose, dehydration, but they do not have the ketones in their urine, so they don't have that Kussmaul's respirations, they don't have the fruity breath, but they will present with dehydration, extreme dehydration, due to those 3 Ps. So pathophysiology for these folks, blood glucose is elevated, they have that polyuria, profound dehydration, so hypovolemic shock is a real potential problem. They don't have the nausea and vomiting, so they're slower to get help, and there is a high mortality associated with HHS. So let's see, I went over that. So signs and symptoms. Extreme dehydration, lethargy, blood glucose extremely high, 1,000 to 1,500 milligrams per deciliter, which is high. Electrolyte imbalances, coma, and death. So therapeutic measures are going to be the same as they were with DKA. So we're giving them IV fluids, we're giving them insulin drip, frequent glucose monitoring, and electrolyte monitoring as well. So again, the only type of insulin that we can give IV is Humulin R. So prevention of these, or HHS, is self-monitoring of their blood glucose, and I'm on slide 51. If their glucose is rising, they need to try to prevent that dehydration by drinking fluids and lowering their glucose, notifying their healthcare provider for that. Okay, so we've gone through the 2 complications associated with diabetes, diabetic ketoacidosis, and HHS. Now let's talk about long-term complications. We all know that there's lots and lots of long-term complications associated with diabetes. So we have macrovascular, which are big vessel changes, and microvascular, which are little vessel changes that can occur. So macrovascular complications. So let me go back just a little bit. On page 830 in your textbook, it talks about over time, chronic hyperglycemia causes a variety of serious complications in persons with diabetes. These can involve circulatory system, eyes, kidney, skin, and nerve changes. Most of the complications occur either from large blood vessels, again, macrovascular complications, or tiny blood vessels, which are microvascular complications. And then as far as looking at the bottom of this, the United Kingdom Prospective Diabetes Study showed that individuals with type 2 diabetes who maintain a hemoglobin A1C of below 7% can significantly reduce their complications. And with for every percentage of decrease in hemoglobin A1C, there are 25% fewer deaths from diabetes-related complications. Tight control can be accompanied by increased risk of hypoglycemia, and even tight control does not guarantee the prevention of all long-term complications. However, it is very important to reduce the risk of your long-term complications, to keep good control of your blood glucose levels. Now, tight control meaning that they keep it less than, if normal is 70 to 110, they keep it 110, 115, 120. That may be kind of too tight for folks to keep that. So, encouraging them 120, 130, somewhere in there, because again, diabetes is that 126 or greater. All right, now let's talk about macrovascular changes. Can include strokes, heart attacks, and peripheral vascular disease. And the circulatory system can be affected, obviously, leading to those changes. And then microvascular complications can occur with our eyes, which can be a retinopathy. They can occur with our kidneys, which can be nephropathy. And then they can occur with our nerves, which can be neuropathy, as well as gastroparesis. They can be involved with infection. We are more prone for somebody who has increased blood glucose levels. Healing is very slow because of the impaired circulation. And let's see, foot complications. We all know about that foot problems associated with diabetes, and those are big, and we're going to talk about those. So diabetic foot ulcers. Foot care is mentioned on 831. I think we've all kind of been beaten the head, hopefully, with diabetic foot care, but these folks should wash and dry their feet every day, inspect their feet daily. If they can't do it, they need to have somebody else to do it. Wear well-fitting shoes. These should typically be leather, and they should wear white or light-colored socks. And if you'll notice the little nursing care tip on the bottom of 831, it says, encouraging them to wear white or light-colored socks. One woman did not know she had a wound on her foot until she saw blood coming through her white sock. Avoid crossing their legs because of the peripheral vascular complications that they can have. Use caution with nail care. They should really see a podiatrist for their foot care needs, for their nail clippings, that sort of thing. But if they do that, they need to clip them straight across. And let's see a podiatrist for calluses or problems with toenails. Avoid bathroom surgery. Everybody should avoid that, I'm pretty sure. And then have their feet checked at least once a year, preferably 3 to 4 times a year for loss of sensation. So, hope for the future. Diabetes control and complications trial is mentioned on, I'm not even sure where that's talked about in your textbook. Because I don't have that highlighted, so I would not necessarily pay too terribly close attention to that. But tight control does reduce complications. However, too tight of control, that might be what I was just talking about. No, that was the United Kingdom, which was the next one. There it is, diabetes control and complications trial. That was mentioned on 830 under those long-term complications, and then the hemoglobin A1C of less than 7 reduces the complications. All right, so care of a patient undergoing surgery that does have diabetes. This is mentioned on 832. So again, remember, illness, surgery is stress on the body, and glucose needs do go up. So even though that those folks may be NPO or are NPO, they're still going to need that insulin. Now, they may not need their oral hypoglycemics, but insulin would be needed. Frequent glucose monitoring is needed. Sliding scale insulin or an insulin drip may be needed, and maintaining their blood glucose from 140 to 180 in the critically ill. And this is mentioned on 832 on the second column there. But critically ill patients also do not tolerate a low blood glucose. Therefore, it's preferable for them to stay 140 to 180. And the use of IV insulin may be needed. So nursing diagnosis, these are mentioned on 833 and 834. There's a nursing care plan that has risk for unstable blood glucose levels that you can read through. And then diabetes self-management education is mentioned here, and this is on the bottom of 834. Disease process and treatment, they need to know about it. They need to know how their body responds. They need to keep up with it. It's not something that you can just ignore and do away with. Nutrition therapy needs to be done. Exercise, which we've talked about. Medications, what they're taking, they need to know that. Self-monitoring of blood glucose, need to know their acute complications. that can be associated with their disease process, their chronic complications, their psychosocial adjustment, because this is typically a lifelong disorder, and then health promotion things. Matthew. Then we have reactive hypoglycemia. Is the overreaction of the pancreas, but this occurs when our blood glucose drops below a normal level following meals, and usually it's below 50. But with this, we have low glucagon levels, low blood glucose levels, and the sympathetic fight-or-flight response is seen there. Let's see, therapeutic interventions include frequent small meals and high-protein, low-carbohydrate diets. And that kind of covers chapter 836 in your textbook. So we can go through a few of these questions here that are at the end of this PowerPoint slide. So what is the desirable pre-meal blood glucose for a patient with diabetes? 70 to 100, 70 to 130, 100 to 130, or 140 to 180? The correct answer is 2. The pre-meal blood glucose with diabetes is 70 to 130. And then, what are risk factors for type 2 diabetes? Select all that apply. Obesity, heredity, islet cell antibodies, metabolic syndrome, or insulin resistance. And these are going to be 1, 2, 4, and 5 are risk factors for type 2 diabetes. The islet cell antibodies are going to be for type 1 diabetes. Then we have what patient should be monitored for Kussmaul's respirations. The patient with type 1 diabetes out of control, a patient with new diagnosis of type 2 diabetes, a patient with metabolic syndrome, or patient with gestational diabetes. And that is going to be the patient with type 1 diabetes that's out of control, because that goes along with diabetic ketoacidosis. And then we have what are the classic symptoms of diabetes mellitus. Select all that apply. Polymorphia, polycythemia, polyuria, polydipsia, and polyphagia. So that's going to be 3 and 4 and 5, polyuria, polyphagia, and polydipsia. And then what meal plan is best for a patient with reactive hypoglycemia, and that's going to be, the choices are plate method, low fat, low protein, low carbohydrate, or frequent small meals, and that answer is frequent small meals.